So welcome everyone. And so today we have one of our thrombosis fellows presenting, and Dom is going to talk about DOAC reversal and current management strategies. This is obviously timely because we're using DOACs, very broadly now for lots of different indications, and using them, for more complex patients, especially in cancer, for example. So it would be nice to know sort of updated evidence on how to manage these patients. I don't know, Dom, you're going to talk about Andexanet and sort of the, what CADET's sort of recommendations are and stuff. So that would be nice to talk about too if we have time. Thank you.
Thank you for the introduction. Yes, my name's Dominic Benez. He's one of the PGY5 GIM fellows doing a thrombosis year. We'll be presenting on DOAC reversal and current management strategies. Go over the objectives first. I just want to highlight the importance of DOAC-related bleeding as an important cause of adverse outcomes, and then go into the role of reversal agents in DOAC-related bleeding and review the current evidence for the use of PCC and Andexanet alpha in the setting of DOAC reversal. So as you know, DOACs are commonly used medications now for the prevention of stroke and embolisms and atrial fibrillation and VTE. However, serious bleeding is a major risk associated with anticoagulant treatment. The annual risk of clinical major bleeding is 2 to 4%, with the 30-day mortality as high as 9 to 45%, depending on what study you look at. Building on my last network round presentation, we know that in comparison to warfarin, apixaban, and DOAC therapy in general has a lower risk of bleeding, at least to a creatinine clearance of 15. Below that, obviously, it can become quite controversial. However, in the DOAC-related bleeding, the majority are gastrointestinal, 30 to 45%. Of course, the one with the highest morbidity and mortality is intracranial hemorrhage, which in some kind of people that do experience bleeding on DOAC has been described as high as 10 to 25%. It's not insignificant when it does occur, especially in intracranial bleeding. In this study where they actually looked at the Aristotle trial, the landmark trial looking at apixaban, major bleeding occurred in around 850 patients, about 5% of the total, of which 15% died within 30 days. The majority of patients that died were within the intracranial hemorrhage arm, which was made up of 76 patients who passed away. You can see if a patient does experience intracranial hemorrhage, they almost have a 45% chance of passing away, while patients who compare GI bleeding or other major clinically relevant bleeding, the risk of death is about 9%. Major bleeding, of course, is substantially increased with the risk of death, ischemic stroke, MI, especially following ICH. And this is especially important to mention as it underscores the importance of preventing bleeding in anticoagulated patients altogether. As I mentioned, in overall, apixaban or DOAC therapy has a decreased risk of bleeding in comparison to warfarin. But once bleeding has occurred, the risk of death, especially in intracranial hemorrhage, is very similar to warfarin therapy. So this study looked at 90-day functional outcome following ICH in about 2,000 patients who either are treated with vitamin K antagonists, particularly warfarin, or in this case, obviously we use the DOAC, but this is an older study, they're using NOAC terminology. You found in almost 40% of patients in both arms passed away within the 90 days. And with an MRS scale greater than 3, which shows quite significant disability, the vast majority had significant disability after experiencing their ICH. Therefore, both DOAC and vitamin K antagonist therapy leads to significant morbidity and mortality. And so it's again underscores the importance of preventing bleeding in these patients. And if found to have bleeding, there's limited strategies to manage and improve hemostasis, especially in patients with intracranial hemorrhage. So when I approach a patient, especially with DOAC-related bleeding, the questions that come to my mind are what is the severity of the bleed? what supportive and interventions have been initiated, what DOAC has been administering last taken, is there a role for reversal, and which reversal strategy? And just to remind ourselves, we typically use the ISTH guidelines to determine the severity of bleeding, where they qualify non-major bleeding as small bleeding, dental bleeding, self-limited epistaxis, in comparison to major bleeding, which is typically either fatal or into a critical organ, intracardiac, intracranial, retroperitoneal, greater than 20 grams per liter of blood loss or hemoglobin drop, requiring more than 2 blood transfusions. And typically, DOAC reversal or the consultations or phone advice I've received is typically within these 4 categories. You have either severe life-threatening bleeding, like intracranial hemorrhage, massive GI bleed, critical organ bleeding, urgent surgery that cannot be done without hemostasis, and ongoing bleeding despite attempted control measures. This leads to the current practice. In dabigatran, as we know, we do have idurcizumab as the reversal agent of choice, and it will lead to complete reversal in minutes and last for 24 hours or more in the vast majority of patients. In apixaban, edoxaban, and rivaroxaban-related bleeding, the current pattern of practice is to administer a prohemostatic agent, in our case, prothrombin complex. This is based on very limited observational cohorts of DOAC-treated bleeding patients, in vitro studies, animal models, and studies in human volunteers. Potentially, PCC may reduce DOAC-related bleeding by providing a large amount of exogenous factors, specifically 2 and 10. This may be associated with a small increased risk of prothrombotic risk. However, it does not work as an antidote for these medications. Again, it's important to note is that the dose of PCC varies on institution. For example, when I was in Ottawa, the dose is 50 units per kilogram with no max dose. Typically here it's 2,000 with potentially another 2,000 administered shortly thereafterwards. And if you look at the studies, they have varying doses, largely because of that's what the protocol chose. Typically, fixed dose is chosen because it's easier for the nurses to administer. Looking at idurcizumab, which was a reverse AD study, had a total of 503 patients who were studied and divided into 2 groups. Group A was uncontrolled bleeding, and Group B was requiring an urgent procedure within 8 hours, and normal hemostasis was required. Obviously, all patients were on dabigatran, and they had received 5 grams of IV idurcizumab. The median time of cessation of bleeding for Group A was 2.5 hours. In 90 days, the thrombotic event occurred in 6% of patients in the Group A group and 7% of patients in the Group B group. And if you take a look here, in the vast majority of patients, within minutes, the amount of thrombin time after idurcizumab initiation decreased back to baseline. And it was sustained for at least 12 hours in the vast majority of patients. You can see some aspect of it wearing off with time as the confidence interval do increase. So that's why I said for some patients, there's, for unclear reasons, potentially due to renal function, that the medication has a longer time for clearance, that there is some rebound after the 24 hours and something to consider. But for the vast majority, hemostasis has been achieved and the dabigatran has been completely reversed. This will become a theme as we go through further studies. The vast majority of these trials did not have a comparative arm. So in dabigatran, they did not compare it to PCC or at that kind of standard of care. But at this time, idurcizumab, of course, is standard of care for dabigatran-related bleeding. Unfortunately, you don't see too much dabigatran usage, probably due to the limited amount of studies and not being covered and overall more expensive than apixaban and rivaroxaban. So in clinical practice, I've yet to use idurcizumab. Polling some physicians here, they've maybe only used it a handful of times for patients who they have seen who had clinically significant bleeding. For PCC, prothrombin complex concentrate again contains 2, 7, 9, and 10, which are the vitamin K dependent coagulation factors. in DOAC-related bleeding is administered to overcome the anticoagulant effect. And again, it doesn't serve as an antidote. The optimal dosing isn't clear. There's no dosing that actually has compared fixed versus weight-based dosing. Again, for ease of administration, fixed-based dosing is typically done. This study looked at whether an infusion of either 37.5 or 25 units per kilogram in PCC reversed the anticoagulant effect of high-dose apixaban in healthy volunteers. So they were given doses of apixaban, and their endogenous thrombus potential was measured pre and post infusion of PCC to determine if there was any partial reversal of the ETP when compared after PCC administration. When looking at this, 15 minutes after infusion in the 37.5 arm, there was a significant increase of about 41% of the ETP, and in the 25 unit arm, it was about 44%. When compared to placebo, it appears that PCC will improve your thrombin potential and potentially improve your ability to coagulate, even in the setting of apixaban, potentially related to the fact that you're trying to overcome that anticoagulant effect. Similarly, studies have again looked at dabigatran and rivaroxaban. This one again took 12 healthy male volunteers. The vast majority of these studies are quite small, who had either received rivaroxaban or dabigatran for about 2.5 days, and they received a single bolus of 50 units per kilogram of PCC versus saline. The study found that PCC immediately reversed the anticoagulant effect of rivaroxaban, but had no effect on the action of dabigatran. Again, we can see here the prothrombin time following PCC administration was significantly improved in the rivaroxaban arm, and it completely normalized within 13 seconds was what the study found, which was sustained for almost 1 hour or 24 hours. However, when looking at the dabigatran arm, the PCC did not lead to any reversal of the prothrombin time, suggesting that potentially related to different mechanisms of action, also the anti-10A inhibitor versus a thrombin inhibitor and dabigatran, that PCC may not be affected in dabigatran therapy. Taking into account these small cohort studies, there are other studies that have looked at retrospectively whether apixaban or rivaroxaban-related ICH who have received PCC, if they have received a good hemostatic efficacy. Hemostatic efficacy is challenging to analyze. When looking at the literature, many people will use much different criteria. This study used the modified Sorority criteria, which has a number of parameters, both radiological and clinical, and where radiologists will review images and use independent study personnel adjudicated to determine primary hemostatic efficacy. It's always challenging some studies will use different criteria to determine this. This study found that about almost 82% of patients that had received PCC between 2015 and 2019 had excellent or good hemostatic response. Again, it is challenging to determine what exactly that means because of the definition that was used. However, not all studies have shown that PCC shows a prothrombotic and a good hemostatic response. This trial, called Retrace True, was a retrospective cohort study over a 5-year period of time, which again looked at the association of PCC with administration of hematoma enlargement. It found that PCC administration was not associated with a reduction in hematoma size or mortality rate. And as we know, and there's extensive literature on this, despite PCC not showing any prevention of hematoma enlargement, what they did find was that blood pressure control in ICH does obviously lead to improvement in hematoma enlargement, and likely clinical outcomes, as many large trials have already shown that in the past. This underscores the importance that potentially PCC is a tool to use in DOAC-related bleeding, but appropriate supportive measures, definitive management is likely much more important to manage the bleeding overall. This comes to the point that overall the evidence to support PCC use in major bleeding is weak. It is unclear if it will improve outcomes in DOAC-associated bleeding, and the risk of thrombosis is challenging to ascertain. However, the presence of major bleeding is definitely a tool in our toolbox that can be used alongside definitive measures. That goes to our new medication, Adanexa alpha. It is a specific reversal agent that is designed to neutralize the anticoagulant effect of both direct and indirect anti-10A inhibitors. It's a recombinant modified human factor that retains the ability to bind 10A inhibitors at the active site with a high affinity. Thereby, it sequesters the apixaban or rivaroxaban or 10A inhibitors within the vascular space, allowing for endogenous factor 10A to increase and reducing the levels of activity of anticoagulation. So there's a number of trials of prior to Adanexa-4, but Adanexa-4 was the first major trial that looked at life-threatening acute major bleeding and the efficacy and safety of Adanexa alpha for reversing the anticoagulant effects of factor 10A inhibitors of apixaban or rivaroxaban, endoxifen, and enoxaparin. There's a single-arm trial that only enrolled 352 patients who had major bleeding within 18 hours after administration of a factor 10A inhibitor. The vast majority of patients had received apixaban, 50%. The second major group was rivaroxaban, which is 36.5%. 70% of the patients had ICH, and about 23% of patients had a GI bleed. This somewhat correlates to what we see in clinical practice. The vast majority of our patients are on apixaban and rivaroxaban, especially in British Columbia, given the lack of special authority for endoxifen and dabigatran. So it is generalizable, at least to the population that we see here in clinic. It did have a quite broad inclusion and exclusion criteria. The inclusion criteria included acute bleeding required urgent reversal, life-threatening bleeding with signs and symptoms of hemodynamic response, the typical ISTH definition for clinically significant bleeding. Exclusion criteria was treatment with a vitamin K antagonist, PCC, dabigatran, planned treatment with the PCC, fresh frozen plasma, or recombinant factor 7. If they had a thrombotic event. Now, importantly to note, they excluded patients who have a severe ICH, so a volume greater than 60 milliliters, or GCS below 7, who potentially would have the most benefit from the medication, but could skew the overall mortality risk of the study. And expected survival less than 1 month. Again, I would say the vast majority of patients with ICH typically will have a survival less than 1 month if it's severe, but it's challenging to say exactly the patients they saw with intracranial hemorrhage, and if they were to undergo surgery within 12 hours. They wanted to look at the percent change from baseline in anti-10A activity and rate if it was excellent or good hemostatic efficacy after 12 hours. Secondary efficacy outcomes was the relationship between decrease in anti-10A activity and achievement of hemostatic efficacy, with the safety outcomes being death, thrombotic events, and development of antibodies to Adanexa alpha or native factor 10 or factor 10A. Having never dosed it myself, Adanexa alpha, this is the protocol that was used in the study, and if approved in BC, and we'll go into what CAD-TH had recommended in their recent review of the medication, is that apixaban in those patients who received rivaroxaban greater than 7 hours ago, the dose was 400 milligrams at a target rate of 30 milligrams per minute, followed by 480 milligrams for 120 minutes. So it's not unlike idurcizumab and PCC and vitamin K, where it's a single dose and the reversal is quite fast. There is, for most patients, almost 3 hours before you can see complete reversal of the medication, complete administration of the medication. Similarly, if they received within 7 hours, you would double the dose of Adanexa alpha and followed by a higher dose of following that of 960 milligrams for 8 milligrams per minute. Following the following the administration of Adinex alpha, it found that in the apixaban arm, the median decrease in factor Xa activity was 93%. In the rivaroxaban arm, it was 94%. Looking at the adjudicated outcomes, about 27% of the patients had the study prescribed blood products or hemostatic drugs between the start of Adinex alpha and 12 hours after the infusion. And about 20% of the patients received an RBC, a RBC transfusion as well. Again, it's always challenging to know how they measure excellent or good hemostatic response. In this case, it was assessed by an independent committee on the basis of pre-specified criteria. They note that the size of the red squares is proportional to the number of patients included in the subgroup analysis. So typically patients less than 75 are underrepresented and patients over 75 are at a larger representation. The study hypothesized that the rate of excellent or good hemostatic efficacy would exceed 50%. There were 5 patients in the efficacy population who could not be analyzed for unclear reasons. They noted that about 85% of patients for gastrointestinal bleeding had good hemostatic response, and patients with ICH had an 80% chance of good or excellent hemostatic response. Then looking at the safety population, they noted about 10% of the patients actually experienced a thrombotic event within the first 30 days of treatment. Of these, the 11 patients had it within 5 days of therapy. The rest of the patients experienced after 6 days, which primarily occur after 15 days. The thought is that the majority of patients experienced this because it was a delayed reinitiation of anticoagulation, potentially leading to a prothrombotic event. It's challenging to ascertain how much of this prothrombotic event was due to the medication alone versus just stopping anticoagulation and their, potentially other risk factors, immobilization, critical care admission, or other medications that could limit the use of reinitiation of anticoagulation. As we see here in the thrombosis clinic, like the biggest risk factor for thrombosis in a patient who has a recent VTE is bleeding, because it will limit the use of limit when we can reinitiate the anticoagulation overall. And again, the majority of thromboembolic events occurred in patients whose resumption of oral anticoagulation was either delayed or who did not restart anticoagulation altogether. So despite this being a landmark trial, there's been a number of limitations. Most importantly, it was a non-comparative study design. It was challenging to draw conclusions on whether any observed effect would be attributed to Adinex alpha alone or due to the lack of consideration for potential confounders. The absence of direct comparative evidence between the Adinex alpha and PCC represents a gap in the evidence. There has been some retrospective cohort studies, which I'll mention 3 and go over, that have tried to look at the 2 medications and compare the hemostasis achieved with Adinex alpha versus PCC. In ANEXA-4 versus the orange study, it matched 322 ANEXA patients treated with Adinex alpha with 88 orange study patients treated with PCC. The study found that after for adjusted 30-day mortality for patients with Adinex alpha was lower than patients who were treated with PCC. The ICH subgroup, patients treated with Adinex alpha had a lower mortality than patients treated with PCC. Mortality risk was lowest for patients in the GI subgroup, but not differ significantly by treatment. So looking at the trial here, you can see in the whole subgroup, it favored Adinex alpha, but in the GI subgroup, there was no statistically significant difference between the 2 arms. Is intracranial hemorrhage, again, is always one of the highest morbidity and mortality associated with DOAC-related bleeding. The majority of these retrospective cohort studies have looked at this question. This study looked at 107 patients from the ANEXA-4 trial and 95 patients in the 4 PCC cohort. The results favored Adinex alpha over PCC with respect to hemostatic efficacy and 30-day all-cause mortality. So overall, from a mortality point of view, it favored adinexa alpha, but in regards to the intracerebral and interventricular subgroup, there was no statistically significant difference. This is largely due to the fact that the hematoma size was minimally changed between the two arms. It was challenging to ascertain the hemostatic effectiveness of adinexa alpha versus BCC in patients with interventricular hemorrhage or intracerebral hemorrhage. Looking at ANEXA-4 versus RETRACE-2, this study compared the occurrence of hematoma expansion and clinical outcomes in patients treated with either adinexa alpha or with the usual care during the acute phase of factor Xa inhibitor-related ICH. It primarily compared patients who had been treated for adinexa alpha hemostatic treatment with RETRACE-2 patients who were treated with the usual care. Of note, 80% of these patients had primarily been administered prothrombin complex concentrate, so it was a good trial to compare to. Overall, the results favored adinexa over PCC in hematoma expansion, but no change in overall mortality. You can see here that the hemostatic on CT imaging favored adinexa alpha quite significantly, with the p-values being quite low, but overall, not only the functional outcome of the MRS score, but also the mortality outcome, so both morbidity and mortality, was unchanged in the two arms. Therefore, CADH actually reviewed this medication back first in July and then re-reviewed back in March of this year, which I will get into. But the first trial looked at that there was unclear inclusion and exclusion criteria in the comparative analysis. Given the lack of randomization and risk of confounding variables, which can lead to overestimation of benefit. Therefore, at least in Canada, there's uncertainty in the degree of the clinical benefit attributable to adinexa alpha, given the inherent limitations of a non-comparative study design. This is what's been reviewed by CADH, especially in July, and somewhat reiterated in March 2023. However, in October of last year, the 15th World Stroke Congress, they did an abstract presentation of ANEXA-I. This is a trial that compared adinexa alpha to usual care. In the usual care arm, the vast majority of patients have received PCC, with the primary endpoint being effective hemostasis 12 hours after randomization. This was based on hematoma expansion of less than 20%, which is rated to be excellent, less than 35%, which is rated to be good. In comparison to other arms, this study actually, at least from the abstract, appears to have a much better definition of hemostatic response. And as well, they looked at NIH scores of less than 7 points at 12 hours and no rescue therapy required. Secondary endpoint was anti-10A activity, which is statistically lower in the adinexa arm, 94 versus 23%. Reading the study is expected to be published in June 2024. Tony did reach out to the pharmaceutical rep who said maybe the results will be available within the next 2 to 4 weeks to further review, but it's unclear when exactly the study will be published. And it's important to note that the anti-10A activity was similar in the apixaban and rivaroxaban arm, and the amount of reduction at 94 and 96% respectively. However, in the edoxaban arm, they actually only found the anti-10A activity to be reduced by 72%. When compared to usual care, the adinexa alpha was associated with a statistically significant 11% overall reduction in clinically, 11% improvement in clinically effective hemostasis. Again, I don't have access to the full results yet, but from the abstract presentation, it appears that the risk of ischemic stroke was 6.5 versus 1.5% in patients randomized to adinexa alpha. The rate of DVT and PE was numerically lower in the adinexa alpha arm, and unfortunately, there was no significant difference in mortality at 30 days, 27% versus 25.5%. So the medication was actually reviewed by CADH, who recommended approval but not to reimburse the medication. The following points were taken directly from the report. They mentioned evidence from a clinical trial demonstrated that adanexa treatment could reduce the activity of factor Xa inhibitors in the blood and improve imaging and laboratory markers of bleeding. However, without a control group, there's uncertainty in how much the observed benefit were due to adanexa treatment rather than chance. Observational evidence comparing adanexa and prothrombin complex contrastate, which is part of the usual care, was uncertain due to limitations of study design and analysis. They state that the cost per patient is about $27,000 for the medication. They estimate the budgetary impact of the medication to be over $106 million. Challenging to how they get to that number. I suspect they say with all patients with clinically major bleeding, as determined by ISTH, would receive the medication if they're on a DOAC. Again, Tony did reach out to the AstraZeneca rep, who says now instead of going through the CADH system to get an improvement and reimbursement for the medication, they'll go through the typical formulary P&T processes in Canada. I don't exactly know what that process is and how that process works in British Columbia. From my understanding, it is a centralized process similar to the federal process, but it's unclear how it will be approved, when, who will approve it. So DOAC-related bleeding is associated with an elevated risk of mortality and morbidity. Beyond idursulfase for dabigatran, there's no well-studied and, more importantly, reimbursed antidote for apixaban, rivaroxaban, and edoxaban. PCC likely partially reverses the effects of factor Xa inhibitors, but no randomized controlled trial has been performed. Adanexa, when published, may give evidence for funding the medication. However, due to the significant costs, I suspect it will be only used for very specific indications. I suspect in the beginning it'll probably be only used for intracranial hemorrhage or maybe patients need urgent surgery. Also, the challenging will be to know where the medication will be stored. I doubt it will be stored at all, both academic and community hospitals. I suspect it will be primarily stored in trauma centers, so in the Lower Mainland, Royal Columbian, and Vancouver General, and potentially in the island, Victoria, and Kelowna. But that goes into the point is that in smaller centers or community centers, their ability to do definitive management is less likely due to the resources available. So potentially would it be more valuable to have the medication there rather than larger academic centers? This is something that will need to be discussed if and when the medication is approved, and more importantly, when the medication is thought to be reimbursed. So even with the strong evidence showing that it likely does reverse DOAC-related, the anti-Xa effect of DOACs, and appears, at least on the last trial, that is more effective in hemostasis in comparison to the current standard of care. How the medication will be administered, I think, will take a number of months to years before we see it on regular clinical use here in our hospitals in British Columbia, anyways. This was the protocol actually developed, PPO developed to kind of go over the medication and DOAC-related bleeding. Obviously, it goes over idursulfase for if the patient is on dabigatran. But if you look on the right-hand side, it goes over what the protocol would be, and it's very similar to the ANEXA 4 trial of how much adanexa alpha to give in the setting of apixaban and rivaroxaban-related bleeding, and of course, edoxaban-related bleeding would also be in that case as well. This was developed by some stakeholders in Fraser Health, Providence, and Coastal Health, for example, Dr. Tony Wan, Dr. Agnes Lee, Dr. Maggie Constantine. Thank you for listening to my presentation.